Good afternoon, and welcome to our second forum on Moving Medicaid Data Forward. I'm glad to see everybody here. It's nice to have the people here in person and the over 400 people who are joining us online. It's a great crowd, and I think people who aren't here or aren't online are probably thinking like, wow, you got 400 and some people to go tune in on Medicaid data? You know, why in the world would that be important? Well, actually, I probably should introduce myself. I'm Craig Thornton, a senior fellow here at Mathematica, and I'll be moderating. But the real question is, why is Medicaid data so important? Well, Medicaid is the largest health insurance program in the United States. There's 74 million current beneficiaries. It's about 20% of the population. But the 20% is a little bit misleading, too, because people come on and off Medicaid at different points in their lives. So that over the course of a person's life, probably half of the people in the United States will be on Medicaid at some time. So this is not some little program off to the side. This is a major source of health insurance for many people, many Americans. Medicaid expenditures are now over $432 billion. That's a big number, even in this town. Medicaid accounts for the largest single item in many state budgets. So states are really worried about this. The federal government's spending a lot, but the states are spending a lot. It may displace education, schools, criminal justice, other things in the state budgets. And of course, given all these things, there's a lot of interest in pursuing new options. How do we think about designing and building the Medicaid program as strong as possible? So that's the Medicaid program. Why are the data important? Well, if you're at Mathematica, the data is the evidence. It's hard to imagine how you're going to analyze something if you don't have any data about it. And today we're particularly thinking about the data that's not the system's awash in data. Every state, territory has tons of data about the Medicaid program. But we're talking about the data that you can use to compare states. So you want to know what's going on here, what you're doing compares in another state. And that data is a little bit scarcer. And that's what we're talking about today. In fact, this is the second one of these forums. As I said, the first one we tried to introduce the TMSIS system, the main CMS system for bringing Medicaid data together. Talked a little bit about its history, current availability, current process of getting the data from the states out to researchers and states. And we also talked about how CMS might make the TMSIS data available or improved to the research community. We ended last time with that question, but it's still a question, and I want people to think about that today when you listen to today's speakers as well. This is all system in design. It's still being adjusted, and the people who are going to use these data to try to answer questions. Today we're talking about enrollment questions, but there are lots of other questions. Give us feedback. There's a comment card, everybody here in person. There's a little comment survey. If you're online, in your packet, there's some email addresses to people, researchers here who are working on the data. Send us your questions, send us your suggestions, and we'll try to respond to questions, and we'll forward the suggestions onto CMS. So today, we're talking, as I said, we're talking about enrollment. We have three really great presenters to talk about Medicaid enrollment. Robin Rudowitz will start first. She's the Associate Director for Program on Medicaid and the Uninsured at the Kaiser Family Foundation. And that many of us have used that website almost daily to kind of figure out what's going on. It's been a great resource. And Robin can talk a lot about what's going on right now in Medicaid enrollment. So we're very lucky to have Robin here today. Next will be Maggie Colby. Maggie's an Associate Director in the Health Division here at Mathematica. And she's going to talk about actually the data. I mean, it's a data forum. And so survey data, a lot of data you can use to figure out what's going on with enrollment, but then with some special emphasis on what's available with TMSIS. Tom DeLeer will then wrap it up. Tom is a professor at Georgetown. Formerly at ASPE. He's been working on Medicaid and coverage issues for quite a while now. He's going to provide his reaction to the first two speakers. And at that point, we're going to open up to hear from all of you. We'll take questions from people online and people from here in the audience. Just a couple of housekeeping things before we get everybody going here. Please turn off your cell phones, other electronic devices. We're videotaping here, so if you're attended in person, the back of your head may show up. If you leap up and down, more of you may show. But anyway, we'll videotape this. And the videotape will be made available in a couple of days on our website. In your packets and online, there are copies of the handouts, and as I said, there's comment cards, survey cards to get feedback. Both did you find this useful? And this is the second, but we have a third and probably a fourth forum in the works, and the topics of those will be decided, probably what we hear back from all of you about what would be most useful to understand about Medicaid data. So with that, I'm going to turn it over to Robin. Robin?
Good afternoon, everyone. And I agree that it's nice to see people here and know that so many people are interested in this topic and tuning in online. Our task today is, as stated, to talk about and give an overview of Medicaid enrollment data. We've seen a lot of changes in Medicaid enrollment over time as things have changed in the program. Most recently, I think enrollment has been affected primarily by recessions and more recently the implementation of the Affordable Care Act. And as stated, we're on the cusp of Congress and new administration thinking about making additional changes to the program. So it's important to understand where we are. I'm going to provide some overview of Medicaid data related to enrollment, but I thought before we started it was good to talk about an understanding of Medicaid eligibility and enrollment processes. Of course, these two things underpin Medicaid enrollment, so I wanted to provide a quick overview of where we stand with those two things. So Medicaid eligibility standards, the federal government, as we know, sets these federal core minimums for Medicaid eligibility, and then states have a great deal of flexibility to expand Medicaid eligibility beyond those minimum levels. Here we see that Medicaid minimum eligibility levels for children and pregnant women have always been at about 138% of the poverty level. Certainly the ACA extended coverage to nearly all adults up to 138% of the poverty level. We have these shaded bars here because, of course, as a result of the Supreme Court, the ACA Medicaid expansion was effectively an option. And seniors and people with disabilities, their minimum eligibility standards are tied to eligibility to SSI. All states have taken up additional eligibility expansions, so all states cover children beyond those minimums, as well as nearly all states cover pregnant women above those minimums. And nearly all states have some type of eligibility expansion related to the elderly and individuals with disabilities through a work buy-in or medically needy coverage. And we also know that 32 states, including DC, have now taken up the Medicaid, the ACA Medicaid expansion. So as a result of all of this flexibility that states have to expand Medicaid eligibility and adopt the expansion, we see great variation in eligibility levels across the country. There are particularly large differentials across states that have expanded under the ACA and those that have not. States that have not expanded Medicaid coverage through the ACA have pretty low eligibility levels for parents. About 44% of the federal poverty level is the median based on our most recent survey. And of course, there is no coverage for adults without dependent children. The ACA also modernized Medicaid application and enrollment processes, which was a really big change from where states were, and how people enroll has a very big effect on their how many people get onto the program. There was a major modernization of how enrollment processes work, designed to create more streamlined and coordinated processes. At this point in time, based on our most recent survey, 50 states have application online, and most states also have the ability for individuals to create online accounts for their Medicaid enrollment. And there's also a lot of states have auto renewals, as well as major simplifications compared to where states were. So all of that to underpin, how many people are actually covered by this program. And I know it seems like a very simple question, and I think I get this question from policymakers or reporters at least once a day. But it is an extremely hard question to answer. And I always say, well, what do you want to know before I tell you just a number? Are you looking to understand trends over time? Are you looking to understand the effects of expansion? Are you looking to understand how Medicaid fits into overall coverage? Are you looking for this point in time number or people who have been enrolled over the course of the year? And I think all of these questions are really important in helping someone who's asking how many people are enrolled in the program to understand what number to give them and what data source is best. We do have a few different sources of Medicaid enrollment data, and I think each have some benefits and some challenges. I mean, what we usually turn to is the MSIS data. That is the most detailed data that we currently have available. So it has Medicaid eligibility by eligibility group, and we have a lot more information. It's also linked to spending data. Of course, the latest available data is from 2011, and not all of it is publicly available. There's always been a lag in the ability to get MSIS data, so we had a project that we had done with HMA to try to get more timely enrollment data. So we would provide these snapshots where we would still try to collect data by eligibility group, and we were able to trend that data over time. With the emergence of the performance metric data, we no longer collect that data, although we still get questions about that data because it did provide a really good source of trend data and also the ability to look across groups. The performance metric data was new. It was like the first time we were actually able to get more timely enrollment data from CMS. And it provides good monthly data, and now with a breakout for adults and children, or for children, and it is helpful in looking at changes since pre-ACA and post-ACA. Unfortunately, from the data, you can't really separate out Medicaid from CHIP, so we often, that's a problem, and we have no other detail underlying any more characteristics about the data. The new MBES data is tied to claims data, and the really beneficial piece of this new release of data is that we could separate out what's happening with the Medicaid expansion group. Of course, we have not that much ability to trend that data over time, and no characteristics are available right now. And then, of course, there's survey data, and I'm not going to really talk about that so much because Maggie's going to talk about that in a minute. The next few slides are just sort of some illustrations of how we use these various sources of enrollment data. I don't think I give a Medicaid presentation without some version of our double bar slide. Many people, particularly in this new Congress and new administration and media as well, are covering Medicaid for the first time and don't really understand the Medicaid program, and I think this slide is critical in understanding the distribution of enrollees and expenditures. So even though it's 2011 data, it's still one of our slides that we use all the time. The next slide is typically we update in our annual budget survey that comes out in the fall. And this data stream in this slide is another standard slide that we really use to show how enrollment tracks with spending. And again, we see it illustrates the point that enrollment grows during times of recession, and we saw another big peak in enrollment and spending as the ACA was implemented. Going back in time, we had used the HMA data that I mentioned earlier, and now going forward, we're using, we had used in this last update the performance metric data. The performance metric data is also pretty useful and helpful in understanding changes from pre-ACA to post-ACA. No, it does not give us how many people have been made newly eligible by the ACA, which is a question we often get. But it is helpful in looking at that snapshot from one point in time to another. And it does have state-by-state data, so we're also able to look at a breakout of, okay, there are 17 million more people than from the summer of 2013. So where did those people come from? Largely, of course, from states that expanded the Medicaid program, with more than a quarter coming from increases in California. We are now able to look at the MBES data to show how the expansion fits into overall Medicaid enrollment. So there are about 73 million people enrolled in the program. And again, I think this is a point. There's a lot of focus on the ACA. And I like this slide because it shows the distribution of the new or Group 8 people compared to individuals who are covered by the traditional Medicaid program, which is still 8 and 10 of Medicaid enrollees. Of course, survey data shows how Medicaid fits into the overall coverage picture. So without the survey data, we couldn't look at Medicaid on the same playing field as how Medicaid fits into the overall coverage in terms of uninsured and employer coverage. So that's sort of where we are with Medicaid enrollment. I think looking ahead, as we noted, there's going to be significant debate over a number of important policy changes related to the ACA, as well as broader financing changes. So estimating the impact of these changes and then tracking what those changes might mean over time, of course, depends on data. So as you know, CMS has been collecting new data through TMSIS, so that would solve all of these problems with disparity in data across these sources. But it's really a continued effort that really needs to happen. The states need to report the data, and the federal government needs to hopefully continue working to collect and release that data so researchers like us can use it. So with that, I'm going to end there and look forward to discussion and turn it over to Maggie.
All right, so Robin gave us a nice overview of kind of what the eligibility landscape looked like, and I think the big takeaway there is that states have a lot of discretion, a lot of options. So what I'm going to talk about is a little bit of a deeper dive into what the data sources are that are available for Medicaid enrollment research, specifically thinking about what you can use that will allow you to look at variation across states. There are some other data sources that I'm not going to cover, particularly in survey data, that would give you a national level perspective on who's enrolled in Medicaid. But if you're trying to understand what the variation is across states as they've chosen different policy options, we really need to be able to get state level estimates. So in that category, I'm going to talk about a few national survey data sources, so the American Community Survey, and then the National Health Interview Survey and Medical Expenditure Panel Survey, which actually draw on the same sample. Then I want to talk briefly about the aggregate level administrative data, which Robin talked about, and that's the Medicaid and CHIP performance indicators and the MBES data. Real advantages as far as timeliness, but not as much of an ability for researchers to use to analyze the data as we have in individual level administrative data, where I'll talk a little bit about MSIS data, which is what Robin had talked about, people have historically relied on, and it's a research analog, the Medicaid Analytic Extract. And then I'll talk a little bit about what's to come in transformed MSIS. And I'll wrap up with kind of what my wish list is that I think is not even reflected in these things. Food for thought, and would love to get the audience's takeaway as well. So national survey data. The advantage with the national survey data is that you can estimate not only who is enrolled in Medicaid, but who might be eligible for Medicaid. So you can start to get at the take-up rate. If we change policies, as Robin said, the ways that people can get enrolled in Medicaid really affect who actually enrolls. So we need to understand both what the eligible pool might look like, as well as how that translates into enrollment. And you can really only do that through survey data, not through administrative data, because administrative data only tells you who successfully got in the door. The other nice thing about national surveys is that they have a whole lot of other topics. So you can look and see among Medicaid enrollees, what other kinds of social programs are they involved in? What are their household characteristics? All kinds of things about them that we don't usually capture in administrative data. The challenge is Medicaid participation, as with most social programs, is significantly undercounted. And when I say significantly, we're talking about missing 20 to 40% of Medicaid beneficiaries in the survey data. So you're missing a big chunk of them. One of the things that I think I've particularly noticed, there's some really good research out there on how significant the undercount is. All of it predates 2014. So the challenges that I see is, Medicaid coverage expanded, a lot more people are enrolled. Medicaid coverage in general has become much more salient for people. So they might be better at knowing whether they're in Medicaid or in something else. So I don't think we actually know for some of the more recent survey data how significant the undercount issue is, although I think some people have begun to explore that on a state-by-state basis and as state-focused researchers. And then timeliness, that release is generally delayed for at least a year. A few specific examples that I think this group should be aware of. So of course we have the American Community Survey. It's now available through 2015. If folks aren't aware, and University of Minnesota folks didn't ask me to say this, it's just a really useful site. They have the Integrated Public Use Microdata Series, which facilitates research that requires understanding family relationships. And if we're talking about Medicaid eligibility, you want to know about what the family relationships are. So that's an easier place to start than with the raw ACS data. It has had a health insurance question since 2008, and it's asking about the current health insurance status. So you don't really have a view of where somebody might have recently been insured and just picked up coverage, or how long they stay on that coverage. It can be used to produce statistically reliable single-year health insurance estimates at the state level and at sub-state levels. So it's really good if you want to track kind of quick changes over time. You can use the ACS to do that. It is 12 independent monthly samples, so the estimates you can think of are about an average for the year. That's relevant when we start thinking about states that changed policy at some point during the year, right? So you're getting an average of what that policy was like if they, for example, expanded coverage in April or September instead of January 1. Researchers have found that in the ACS data, people are accurate about 76% of the time in reporting their Medicaid enrollment. This was using data linked to 2008 administrative data. Really important, that varied from 66 to 88% by state. So it's, again, can be hard to compare across states given that the undercount can vary so dramatically by state. And interestingly, people were incorrect about equally as often in saying they were uninsured or that they had employer-sponsored insurance when they, in fact, were on Medicaid. If we move to looking at the National Health Interview Survey, this is currently available also through 2015. What's different here is the way that they ask the question about health insurance status. So you get health insurance coverage at the time of the interview, and for non-covered household members, the length of time that they've been without coverage. The current questions were actually introduced back in 1997, so you have a very long trend on that. And they are planning to make some minor adjustments in the questionnaire in 2018 for those of you who are planning way ahead. So you can't do annual state-level data with NHIS, but you can get some state-level estimates by combining years, or alternately, if you have a group of states, like expansion versus non-expansion states, you can get those grouped together to produce a single-year estimate. The Medical Expenditure Panel survey takes a subset of the participants who participated in the prior year's NHIS and goes even more in depth with those households. So you get it's a panel design, so you have several rounds of interviews that cover 2 full calendar years. The really unique thing here for people who are interested in looking at Medicaid enrollment is it's really the only thing I'm aware of where you could track what happened when people exited Medicaid, or where they were just prior to entering Medicaid. So you have the ability to track somebody over time. And again, it's also got detailed information on the duration of insurance coverage, uninsurance status, and it's got medical expenditure data that it can be linked to. So that's the big survey data that is useful to be thinking about when you're looking at state-level estimates or something smaller. We're talking about aggregate-level administrative data. These are the sources that Robin was really drawing on. And the 2 biggest ones are the Medicaid and CHIP performance indicators and the MBES data. This is really timely, and it's easy to use for broad monitoring of trends, which is helpful for people who are trying to keep a beat on how quickly Medicaid enrollment is changing. So again, the performance indicator data are already available through November of 2016. That beats everything else I have talked about or am going to talk about by a long shot. And the Medicaid budget and expenditure system data are available quarterly at the state level through that first quarter of 2016. So this gets out there in the world quickly. And as Robin mentioned, MBES gives you a chance to see what that count of expansion adults looks like. The challenge is it's aggregate data. So as researchers, we really like to unpack it, and you can't unpack these. It's also difficult because you can't fully reconcile these two with each other. So if you're trying to do that, don't worry about it too much. It's not really possible. There's very good detailed methodology notes on both pages on the Medicaid.gov site, but really it comes down to they treat limited benefit enrollees differently, and it's a difference in kind of the ever enrolled versus a point-in-time count of enrollment. So they just won't ever quite match. Now, what I want to talk about as kind of our last data source to think about is individual level administrative data. So with the survey data, we had an undercount problem. We didn't know if we were getting the whole universe of Medicaid beneficiaries. But the nice thing was we understood everybody who might be eligible for Medicaid. This is kind of the flip side, where we have the whole universe of people who are eligible for Medicaid at least today, but we don't know, or who are enrolled in Medicaid at least today, but we don't have that kind of awareness of who might have applied or who might have been eligible to apply. So these give researchers the flexibility to examine different subgroups of beneficiaries and track them over time. And I'm sure many people in this group are very well aware, but you can think of MACS as like a research-ready version of MSIS, where the major distinctions is that MACS has final action claims, and they're reconciled to the calendar year that the services actually took place. So MSIS has a mix of original claims, canceled claims, replacement claims, and they're submitted in the calendar quarter that they were paid. So MACS is just kind of cleaned up and really better ready to answer the research questions you might have. Historically, the big challenges here have been that the demographic variables are relatively limited. A lot of the things that you'd like to look at just aren't included in the standard files that states had submitted to CMS, which is also partly why the survey data had been so appealing, right? You could find out all these other things about Medicaid beneficiaries that you couldn't do even if you had access to timely MSIS data. Another challenge has been that the standard eligibility categories in MSIS and MACS aren't designed to track the Medicaid expansion population or other key policy relevant groups like pregnant women. So you have to get creative in how you're going to identify those groups if you use MSIS and MACS. No insight into what happens to beneficiaries during periods where they're not Medicaid eligible. We'd still need survey data for that. And a timeliness issue. I know Robin mentioned that they're not available any later than 2011. There are data that are available for some states, but just not the full set of states. So as recently as last month, you could get MACS 2014 data for 11 states. So certainly a ways shy of 50, but might answer your question. And now we're about to move into TMSIS, which is really exciting because it brings in the improved potential for timeliness. TMSIS data are submitted on a monthly basis. And so it's at least possible, and MSIS data were coming in quarterly, in TMSIS they're coming in monthly. It's at least possible that that could be translated to the research community in a more timely way. Really exciting for people who had been relying on survey data to learn more about the holistic picture of Medicaid beneficiaries. There are new variables that are going to be available in TMSIS that will help us better understand the demographic characteristics of enrollees, as well as categories of eligibility that we didn't have specifically defined before, like pregnancy, detailed information on citizenship and immigration, SSI status, level of care status for people who might need nursing home care, and reasons for an eligibility change. So all of that's really exciting kind of just in the beneficiary information file. TMSIS will also include a whole new set of files that are being collected from states that are around their managed care, around their provider networks, and around third-party liability systems. So what that lets you do if you're interested in Medicaid enrollment is to understand how different enrollees are getting connected to health plans and providers and look at those patterns to see if they point in policy directions. I will say there are a few caveats to this. It's not out in the world yet. There's still some work to do to understand the data quality, expected ranges and fluctuations over time for all of those new data elements. And usability is probably going to vary by state at first. Researchers should probably go cautiously with new data elements. I think for those of you who have worked with new data systems as they're coming online, that's not a surprise. People tend to find things with the data as they begin working with it. So we would expect that the quality of that data will improve over time once states are kind of past that transition point to TMSIS. And it's, of course, possible that the new TMSIS data formats may affect the old data elements that are available in MSIS, just with the conversion of formatting. So we've talked about the range of what's available, what's needed and hoped for. I'm sure this group and our group on the webinar has great ideas, and I would love to hear them. And Tom may want to weigh in on this, too, to get us started. But I will give my own personal wish list. First of all, I would love if we could keep the eligibility hierarchy in administrative data in some way, thinking about all the ways that somebody could be eligible besides their primary basis of eligibility. And when Robin was mentioning, the Affordable Care Act introduced the modified adjusted gross income standard for being assessed eligible for Medicaid on an income basis, there may be people who are currently eligible on an income-related basis who could also have qualified on some other basis. And it would be great to know kind of all of the buckets that somebody could fit in so that we could really understand the impact of policy alternatives that are being contemplated. For example, just because somebody perhaps lost eligibility as a new adult, that doesn't mean they actually lost Medicaid eligibility entirely. They might shift to a different eligibility group that existed before. In some of the states that have done some work on this, I think California actually has some graphs out on their website. There's been a big transition of people from non-MAGI eligibility codes into MAGI eligibility codes, and that's generally just people moving from one aid code to another, not actually a loss of enrollment for people who are in non-MAGI aid codes. If there are significant changes in policy that change eligibility for big groups of people, it would be great to update the aggregate reporting requirements for that quickly. I think Robin kind of alluded to, nearly immediately after Medicaid expansion, everybody wanted to know who are the new adults, and we couldn't quite answer that question of who are the new adults. So to the extent that something parallel to that comes to be over the next year or so, it would be great to go ahead and update the aggregate reporting requirements to get that in so we're prepared to be able to answer those questions. And then my last thing is I would love to understand more about that survey validation research. I don't think the need for survey data goes away even with TMSIS. They're complementary. But the magnitude of the Medicaid undercount post-expansion could be very different than what it was like in 2008. And I would also love to understand sources of cross-state variation in the undercount so that we can really understand, all of these different policy changes that states have made or choices that they've made. How is that playing out in their undercount? Just a few things that come to mind. Is it states that use managed care organizations where people get confused about whether they have employer-sponsored insurance or Medicaid? Is it states that have enrolled their beneficiaries in qualified health care plans through the marketplaces? Where those people think of themselves as having marketplace coverage or private coverage? Is it Medicaid? A lot of states are moving to support Medicaid beneficiaries' enrollment in employer-sponsored insurance. Do those people think of themselves as insured by their employer or insured by Medicaid, even if Medicaid's providing the support? And then there's kind of this long-running question of how Medicaid programs have branded themselves and how that affects beneficiaries' understanding. So a lot of potential hypotheses here. That we could look to explore in kind of what's going on with that survey undercount. So my discussion question was what's on your wish list, and maybe we'll let Tom take that one up first.
Thanks, Maggie. Tom? And we will come back to Maggie's question for the group.
Well, thank you. Thanks to Mathematica for putting together this series of excellent research forums on Medicaid data. And also thank you for including me in this panel. It's very nice of you. The Medicaid is an incredibly important program. As Craig mentioned, 74 million people on average per month That's a lot of people. By comparison, marketplaces have less than 10 million people per month on average enrollment in a year. They get a lot of attention, but Medicaid also gets a lot of attention, but probably not as much attention as it deserves. A lot of people are touched by Medicaid over the course of their lives, especially if you think about CHIP and long-term care, which we haven't really been talking about too much. And it's also very important because without Medicaid, a lot of individuals would be without coverage. By contrast, Medicare Part D, some estimates from the research community suggest that maybe up to 75% of non-dual eligible Part D enrollees would have had private coverage without the program. The estimates for Medicaid, if we have good ones, are much, much, much lower. But keep in mind that Medicaid is going to remain an important program regardless of what changes might be made or what state devolution might result from current policy discussions. It's a large, important program and it's not going away, even if it's changed in some way. So we're going to need quality data to evaluate it and to study it. And it has to be made available both to the policy community and to the research community. And that need is greater than ever. These were two really great presentations, I thought, going over both existing data sources and their limitations, and going over new data sources and their limitations. I've already downloaded the slides. I'm going to hold on to them and study them over the next few months. And I'm sure everyone in the audience already has the slides, and everyone in the webinar should certainly download them and hold on to them as well. It's going to be a great resource. So it's clear to me from those presentations that TMSIS is, despite its limitations and its potential limitations, is a great step forward. And the many people involved with bringing it to life really deserve our thanks for the great efforts they put into this project, which is not done. So, I couldn't help thinking that learning about TMSIS is a little bit like maybe going to an auto show. You're learning about these new navigation systems. I want that. New, better reliability. Oh, I definitely want that. Self-driving cars. Yeah, I want that. And then you leave the auto show and you're still taking the metro home. So that's sort of where we are with TMSIS, I feel like. But, Maggie asked for my wish list, so I'm going to give it a brief wish list. First one is maybe seems pretty basic, but what we really need is data that provide us with the ability to evaluate state-level policies well. Today there's great variation across states in Medicaid policy, not only in terms of eligibility, but also in terms of their benefits, payments, and in many other dimensions. And this isn't just an expansion versus non-expansion distinction. There's a lot of variation within expansion states, a lot of variation with non-expansion states. Some non-expansion states in some dimensions are ahead of expansion states. And so there's a lot of variation here. And we need data systems that enable both researchers and policymakers to be able to evaluate specific state policies without having to lump states together just as a big expansion bucket or non-expansion bucket. So they need to be detailed enough to drill down at the state level and at the subpopulation within the state level, and also have comparable data from control states or from other populations within the same state for analysis. Survey data, even as excellent as the ACS is extremely limited in its ability to do this, in my opinion. For example, estimating take-up rates, even Medicaid take-up rates at the subgroup or the eligibility group level within states is really challenging, especially for small states. There's measurement error both in the numerator and who's covered by Medicaid, as Maggie alluded to, but there's also substantial measurement error in who's eligible in the denominator. And when you have measurement error in both the numerator and denominator, it really creates a lot of statistical challenges, and basically you get a lot of noisy data. And when you're also trying to line up these noisy estimates across years to look at trends, it can be a very challenging exercise. What to do? The Commission on Evidence-Based Policymaking, or the Murray-Ryan Commission, has been pushing the idea that federal surveys should be linked to administrative data. So as part of this wish, I certainly hope that Medicaid data will be included in this effort going forward, certainly once the Medicaid data are available. So that way, the administrative data will help improve the federal surveys, and maybe reduce a fair bit of this measurement error. The existing administrative data the EMSIS is too old and has too long of a lag to be useful in a lot of state-level evaluations. You can do a lot with other CMS administrative data, as Robin pointed out, but these two have limitations. So TMSIS holds a lot of promise, and I'm extremely excited about it. But as Robin pointed out, it's going to require the continued and enthusiastic state and federal participation in order to have TMSIS be a good data source into the future. So that was wish number one. Wish number two, I'd like to see data that will help us understand what happened to Medicaid beneficiaries after they left Medicaid, and also what they were doing before they entered Medicaid. Survey data and panel data helps a lot here, but drilling down to specific state policies using those data is an extremely challenging thing to do, given sample sizes. And moreover, TMSIS is not necessarily going to help solve this problem. I'm intrigued, though, by the other new data features in TMSIS, such as TPL. In an evaluation of Wisconsin's pre-ACA Medicaid reforms, I was part of a large evaluation team. Then we linked state Medicaid enrollment databases to state TPL databases and also to state unemployment insurance earnings records. And this enabled us to look at that question about where Medicaid enrollees were before the enrollment in a somewhat limited way, but an interesting way, I think. And so, first, I hope we'll learn more, perhaps in future research forums, of what we'll be able to learn from these new features of TMSIS, such as TPL. And also, going forward, maybe this is really the wishing part of the wish list, is I hope TMSIS could be linked, at least within the federal government, to other data systems, such as MIDAS, which holds the marketplace enrollment data, Social Security earnings and eligibility systems, or to existing federal surveys. So thank you, and thank you again for letting me participate in this forum.
Thanks very much, Robin, Maggie, and Tom. So now I want to open up to the panel and see if you guys have any questions. I might first just ask whether the panelists want to respond to anything, any of Tom's wishes, or we'll just jump in here. We'll just jump in. So I'll take it. Carmen has a microphone. She can come around and just state your name and affiliation, ask your question. We'll take one question from here in the audience, then we'll switch to the webinar. If you're on the webinar, you can use the widget to answer your question. Again, give your name and affiliation. So, Deborah?
Hi, my name is Deborah Lipson. I'm with Mathematica Policy Research. I just want to expand on Tom's point and something that Maggie and maybe Robin mentioned as well. Even if we don't know exactly what happens to people either before or after they're enrolled, is there anything in any of these data sources that help us understand the churn on and off Medicaid? In other words, can we track the numbers or the types of people who may go off of Medicaid or CHIP even and then come back on to Medicaid or CHIP? Would they have the same ID in the system? Is there any way to use any of the current data sources to determine the periods in which people may lose eligibility on the short term?
I'll take that question. I would say yes, we can look at churn with administrative data. So you can look and see, generally states do have the ability to, you have kind of multiple enrollment spells for someone, and you can see whether they are enrolled or not enrolled for a continuous period of time. So.
Anything about their characteristics?
Well, you could keep anything that was linked to their demographic information in the data source. So I do think you can look at churn outcomes with administrative data.
Thanks. Keenan, do we have a question from the web?
We have a question from Donna Friedsam from the UW Population Health. Her question is about all-payer claims databases, whether there's been any experience linking Medicaid data to all-payer claim databases, and what the, I think, functionality of that would be.
if we've stumped the panel and you're in the audience, you know, raise your hand.
We did ask that question on our annual budget survey, what states were doing with all-payer claims databases, and I don't have the information off the top of my head, but I can get back, or at least point to what we found in terms of linkages with that, if I can get back to that survey.
Any other questions here in the room? Henry?
So this is Henry Iries from Mathematica. So I wanted to come back, Tom, to what you said. I think it was, one of your wishes was federal and state enthusiastic participation in TMSIS. And as a community of users here, we're mostly researchers, I'm sure we would endorse the wish for enthusiastic participation by the folks who generate the data that we're going to be using. So my question really is twofold. One of them is, what are the reasonable incentives that we might think about to support states' enthusiastic participation? Perhaps I'm thinking about administrative incentives focused on enhancing the enrollment data reported by the states. And the second part of my question is really, what can as researchers do to help states understand the value and benefit from doing research on enrollment, and particularly cross-state enrollment?
As Tom's thinking about answering the question, I can tell researchers are not karaoke fans. You really need to hold the microphone in front of you.
You want me to redo that?
Yeah, no, you don't have to redo it. But Tom, if you can make sure that you put your question in context in case people didn't get off.
Well, it's a great question. So I agree that the incentive, states need to be given incentives to be, they might be enthusiastic, but they're not going to allocate a lot of money within their budget to do data systems if they don't have either federal requirements to do so or maybe some matching federal money to do so. So if we're moving to systems, federal systems that change the federal match rate for state Medicaid spending, that will tilt the state's incentives to spend money on these data systems unless we offset that with enhanced federal requirements to do so. But maybe there's people who have worked more with a variety of states. Some states are quite enthusiastic about participating in these data systems, and others are not. My vague recollection of Wisconsin is we had excellent data systems when we were there, and they shared those data. The state was quite willing to share those data with the University of Wisconsin, and yet they were quite lagging in their participation in MSIS at the same time. So I don't know why the reasons for that might have been, but I think there's probably a state-by-state basis of what inhibits states from participating fully in these systems. And then as far as researchers go, I think researchers should be enthusiastic participants in helping states evaluate their policies. And sometimes we can be a little egg-headed and only want to do national evaluations because those are the sexiest. But state-level evaluations are probably the most important. And if we can be useful to states, states will be more likely to want to provide the data.
I'll pick up on that as well, Henry. One of the things I think states would find value in, or more value in the federal level administrative systems, is if they could get data back out to understand how they compare to other neighboring states or states that they view as kind of like their own program. I think there are a lot of state administrators who are trying to be really creative with their Medicaid programs and have a hard time understanding what the apples to apples comparison to another state might be. So to the extent that we can create tools that states can access relatively easily to understand how other states are performing that they view as being like themselves, I think they'll be more motivated to participate in the data submissions because they can kind of see how it's directly benefiting them on the back end.
And this is Barbara Richards from CMS. Just to tag on to what Maggie and Tom said and responding to Henry's question. At the moment, we, as an agency, provide states 90-10 matching for their eligibility enrollment. They're basically their IT systems, eligibility enrollment, MSIS claim systems. And so they already, from a financial perspective, have an enhanced match 90-10. We put 90 cents on the table, they put 10. So there's a significant federal sort of incentive from the financial perspective. We also recently have issued an we call 90-10 regulation that allows CMS to slightly tap a state's operations and maintenance fund from their systems so that we can sort of use a scalpel if they are not reporting to us in a timely way. We have not used that yet. We're trying to obviously encourage states to submit through TMSIS and doing that with rapid speed. But we now do have a regulatory requirement that allows us to use a small scalpel to take their 75-25 operation and maintenance funds to pull back if they're not reporting. Again, whether we'll be able to use that in the future, at least we have the ability there now.
And I would just, way that the current Medicaid system works and that states pay for services for eligible individuals and then draw down federal matching dollars has always, beyond the administrative systems, getting that claim data right, and now the ability to link enrollment to the claims data has been a very large incentive. So there's always been better data on spending, because that's how states get their money. So yeah, so that's a big incentive.
All right, so we'll look for more enthusiasm, and we have lots of levers to help encourage enthusiasm. Keenan, you had another question from the web?
This is from Leighton Koo with George Washington University, who says, we seem likely to have more state flexibility, whether through 1115 or 1332 waivers or block grants. Can you comment on how TMSIS will be able to keep up with greater flexibility across states?
Well, I think, and Barbara may want to jump in on this one as well. We'll see, but maybe not. So, I think a big enhancement of TMSIS is all of the additional variables on eligibility criteria that weren't available in MSIS. So hopefully that gives you at least one additional point of flexibility to try to keep up with all of the different ways that states may pursue different policies. That may be an area, kind of to one of my wish list items. If we make any other major changes, any new flexibilities that aren't currently available to states right now, that would be something that would be nice to incorporate sooner rather than later in administrative data reporting requirements, so that we can kind of keep an eye on if states are pursuing that new flexibility. I think TMSIS will be significantly improved over MSIS for keeping up on those variations in state policy, but it could add a new direction still.
Well, sort of comes back to your hierarchical eligibility. If you change someone's eligible in a new system, you want to know what else it would have been eligible otherwise. So you track that. Was there another? I'll take here, and then we'll go to the back. Yeah.
Hi, I'm Kathy Whitker with Apt Associates, and I was hoping that you could all comment a little bit about which of these data sources, if any, include information about what programs people are enrolled in once they are enrolled in Medicaid, thinking about managed care versus not managed care, or some of the specialized managed care programs like long-term services and supports managed care. They're becoming more and more prevalent across the states. So do we know which buckets people are being placed into, or just they're in Medicaid?
I can answer that question very briefly. There's another whole set of data collection efforts that we've been doing in conjunction with CMS for the last couple of years to collect information on at least managed care enrollment and the different types of managed care plans. That is a separate report that now comes out on a regular basis and much more timely than it was before. So at least in the managed care arena, you can get that information from another source.
There does exist the ability within TMSIS enrollment to see the managed care arrangements that a person is enrolled in. And actually, TMSIS now has more of those buckets than it used to. So there were maybe 5 or 6 plan types that a person, or plan buckets or types of plans that folks could be enrolled in. That has increased, and it is tied to regulations and the new managed care regulations in a lot of ways. So that does exist within the enrollment file. And of course, we now have a little bit more information within the managed care file that would actually give you the operating authority of those plans, and more information that you might have previously had in a different reporting stream is now within the TMSIS reporting stream. Oh, I'm sorry. I'm Vivian Bird with Mathematica.
Thanks, Vivian. Keenan, back to you.
We've had a few questions about which data sets are publicly available. So maybe the easier way would be to ask, are there specific data sets that are not publicly available at this time or difficult to come by?
These are TMSIS data sets or data sets in general?
Well, so it's sort of much like Tom's comment about you go in and you hear about all of the great features of the new car, but you go back home and take the metro. You can't drive the TMSIS car just yet. That's still not publicly available, but all of the survey data that I talked about are publicly available. They're actually links in the presentation slides, so if folks download those and kind of go directly, that should take you right where you need to be. And there's a data request process for MSIS and MACS, so some of those years and data sources are available for administrative data. And the performance indicators in MBES you can get right from the Medicaid.gov site without any special permissions.
Thanks, Maggie. Did we have a question in the back, I think? And then we'll come back up here in the front.
Hi, Chris Armstrong. So I'm a data scientist and applied mathematician. And I had a question about, I don't know a lot about Medicaid, but you were talking about like underreporting and sort of like discrepancies in enrollment data and so on. I guess I have maybe a two-part question. Do you know what the extent is now to which the government is using data analysis to identify where underreporting might be happening? And secondarily, I don't know if anyone would know this, but at the state level, is there any consideration of getting like reporting from maybe non-traditional sources? For example, maybe like churches or schools or wherever people may work, if they're not voluntarily reporting it at the doctor's office or something like that.
So I'm not aware of additional federal efforts to look at the undercount issue. There might be. Many of those studies that were using 2008 data as kind of the most recently available were published in 2013 or 2014. So they're pretty recent studies, but to get a comprehensive set of administrative data and link it to survey data, had to kind of go back a few years from that to get a full set. And so I wouldn't be surprised if something is being planned, but I'm not aware of it yet. As far as reporting from non-traditional sources, I do think there are a lot of state-level efforts to understand more about, state surveys to understand what's going on with their own population. I know California has an California Health Interview Survey that they've been doing for many years. Other states have their own state-focused surveys that might be useful if you're only interested in that state. They generally can't be compared, from one state to another, which makes it challenging. Usually they are doing more traditional survey methods for those, where they're, calling telephone numbers to try and do a verbal interview that way, rather than kind of going out to churches or community locations.
Just want to take one on the web, then we'll come back up here. Oh, okay. Up here.
Deb Potter from ASPE. I just wanted to follow up on a couple of points. Someone asked about the availability of the public data, the survey data, the health interview survey, and the MEPS data. If you want to make estimates about state specific, if you want to make estimates of expansion versus non-expansion, you have to go into the data center to access those data. So it's available, but there's additional levels of security around those data. With respect to the undercount, the American Community Survey has continued to do research on how the questions around health insurance should be measured, and that work is still ongoing.
Thanks. I had a question for you guys, that if we're using this data to compare states, and states' Medicaid policies differ so much, how do you find a set of states where you think you're actually making a reasonable comparison? And so, you know, and the plan data is available at CMS, but you know, there's lots of other characteristics. So is there a, and I know individual researchers have worked hard to put together kind of comparisons of state policies, but is there a place, a source, where people want to say, well, am I going to line up a couple of states and that they're reasonable comparisons, similar kinds of plans, similar coverage decisions? Is that possible?
I mean, I think there's, you know, this adage in Medicaid, if you've seen one Medicaid program, you've seen what, I mean, so I think, but I do agree with Tom's point that you can't, you know, especially as there are more expansion than non-expansion states, you know, talking about these large groups is often, you know, you're comparing Montana and New York, you know, in one group of states. So I don't think you can really, those large groups are not that telling. I mean, there has been more individual level analysis, particularly around expansion, where researchers have looked at aligning states to see, you know, I think the ones that come across are, you know, Kentucky or looking at Arkansas versus Kentucky and Texas. So you're looking at some to see what happened across like a set of states making either similar or different decisions.
Please, question here.
Jeffrey Cooper with CooperSoft. I noticed that you all mentioned wish lists, but what about disruption? How do we really change the focus now that what we've done before hasn't really gotten us to a point that we can really make decisions that inform policy makers, because you're still looking at it from the state level. But if I'm a member of Congress, how can I extrapolate data from the research that you're doing that would empower me to make better policy and represent my constituents? And I think it's true for any legislative body. We don't have the tools to be able to do that. So what tools do you need to do your jobs better that would inform the policy-making process?
So I can try and take that one. Tom and Robin can jump in as well. I think one of the most important things for policymakers is getting timely information. I think they're going to feel a little stuck if they have information that's dated by several years and trying to make decisions about kind of what's the next policy move that they should make. The climate right now certainly seems to be to give a lot of flexibility to states, which might be why we, you know, at present there might be Congress people might be looking for their state level folks to bubble up what they'd like to be doing with the Medicaid program, and that you know could inform what kind of tools people want to see. I think things that are kind of more simple and boiled down aggregate level statistics can be much more accessible to folks who aren't researchers who don't want to dig into the data in a really detailed way. That's probably why Kaiser has been so incredibly popular with all of the great summary statistics that they've produced. People kind of know they have a one-stop shop to get a good snapshot of what's going on in the Medicaid program.
I mean, just to follow up, I think these new data systems, I mean, hopefully the end products that would come from a data system like TMSIS would be a set of state-level data that could be used to compare across states on what's going on, but also sub-state level data, so community-based data on what communities might be affected, on how, you know, who's enrolled in Medicaid, what services they're getting and how much we're spending on different populations. And so this, and I agree with you that to date, some of the data systems we have not been up to the task to provide timely information at that level of detail to policymakers. And so the hope is, my hope is that the TMSIS system, will enter into this new era of people being enthusiastic of getting information about this, this important program and provide it to policymakers. But I guess it remains to be seen what products will come out of this, and whether they'll be useful.
I think it's a challenge because clearly the policy discussion is moving forward, and there will be a lot of debate about the future of the Medicaid program around the ACA and changing the current structure. That's not going to wait for the data to catch up. So I think it's a big challenge, particularly with some of the current proposals that are out there, and talking about even setting a base year is not an easy administrative task with our current data sets.
But if I'm a member of Congress, how do I link up with my colleague who represents Pennsylvania and Ohio? How can we link up, come together from a policy perspective? What works best? What's going to be best for both of our districts that we can find consensus on or agreement? What are those tools that are easily accessible that we can all compare the same data with in terms of advancing the conversation moving forward?
I think, well, go ahead. I mean, one of the things, particularly around the ACA debate, there's been research looking at new coverage and uninsured rate. So that data is particularly helpful. You can see differences across states based on different decisions that they've made. And in looking at increases in enrollment, and many states have also been collecting utilization out, how many beneficiaries are accessing services that they haven't been able to access before. So I think particularly around Medicaid expansion and the ACA, some state-level research has been beneficial to track enrollment, reductions in the uninsured, and while it's a little bit early to track true outcomes, you can definitely see changes in utilization patterns, as well as, other economics on the expansion. These are beyond these enrollment data sources that we're talking about, but I think those are some of the metrics certainly that that states are looking at in terms of the ACA and Medicaid expansion.
I think we had a question up here, Henry, and then.
Well, I wanted just to jump into this.
We have to use the mic because no one can hear you online if you don't have the mic.
Right, so, and I'll hold it close.
You got it.
I'm learning karaoke here. So just to jump into this conversation, I think it's really an important question. What are the tools that are important for researchers to have to address questions that are really important to state and level congresspeople? And one of the tools that researchers use are questions. What are the questions that are really important to ask? And I think we often get caught up in our own echo chamber about what are the questions we want to get answered. But we've got to, and this is where I think congressional colleagues can, at the state and federal level, can help us remind us that they want to know basically, and to oversimplify things, two questions. Does it matter? Does enrollment in insurance matter for people's health and welfare and even employment? And then how much does it cost? But the matter part of it is really important. And we can talk about different patterns of enrollment from state to state, but ultimately we also have an obligation, it seems, to say that enrollment matters in terms of people's ultimate health and welfare and ability to be productive in life. And that means linking some of the data that we have on enrollment to other surveys that have those kinds of items. And so I think that the kind of question you just raised is always an important reminder to the research community that we've got to go beyond just enrollment data. We've got to link them to the other sources of data that will help us understand why and how enrollment in health insurance matters to people.
Thanks, Henry. Any other questions here? I think we've exhausted the online group. I just had a question which I don't think there's an answer to, but I thought I'd ask anyway. Now that there's the mandate, presumably the IRS has data not on Medicaid, but on coverage rates, at least the number for people who file tax returns, how many people checked all the boxes on their return. Has IRS released any of this stuff? Do we know how many people paid the penalties and how many people said they were covered for a full year? It's not a data set anybody mentioned, but I wondered that
they recently put out the Office of Tax Analysis recently put out a whole slew of reports, I think, in this past month, which I would encourage people to take a look at. I certainly haven't digested them. But interestingly, my understanding, the tax system will be collecting insurance coverage information on the universe of tax filers, and non-tax filers as well, because even individuals who don't file taxes often will be receiving their insurance from some entity which is required to report that enrollment, that coverage to the IRS. And so it could well be that the IRS will be putting the rest of us out of business. So maybe CMS and IRS can duke it out, and we'll see.
By the time maybe we can go get the website, and we'll put it up on our slides after the presentation. People want to go find where to get that data. Well, if we're not seeing any other questions, please, as people think about what they, when you get home, think, I wish I would have asked that question. You can email. In this handout, there's a number of people, researchers there, whose names are listed. Or use the comment cards or the online survey card to get your questions. And both about what you like, questions about this stuff. Also topics, what else would be interesting? We've talked about basic TMSIS data. We've talked about enrollment now. There's 2 forums coming up, one in June and then one in October. As I said, the topics will be decided when we see what people are really interested in. And of course also on the continued development of TMSIS data and how that gets rolled out. I think my job is then to say thank you for everybody, and please a round of applause for our speakers. Thanks. And if you're here, the network reception starts right now. If you're at home, go to the fridge. Thanks, everybody.